Hello everybody, welcome to Beyond the Boards, and today we have our first episode in our ECG series. The first thing that I want to start this video off with is what one of our highly astute cardiology professors has always told us, and that is there is no spot diagnosis in the ECG. You always have to look at the patient and take the clinical circumstances into consideration, and then interpret the ECG as such. At the end of the day, you want to treat the patient, not just the ECG. The other thing that I would highly encourage you to do when you're looking at an ECG is to be systematic with your approach. And the first thing that I like to do when looking at an ECG is to check the name, the date, the calibrations, and once I make sure those are in order, only then I can proceed to actually looking at the ECG. So I just take a quick scan at the whole ECG and see if there's anything that catches my eyes immediately. And obviously the striking features here are the wide QRS complexes and the ST segment innervations and depressions. Then we can go into the details of the EKG. I like to start by trying to find the P waves. So we can clearly see the P waves in lead V5. And then I'd like to assess the shape and the size of the P waves. So in terms of the shape of it, the P waves should be upright in the majority of leads and negative in lead AVR and biphasic in lead V1, as is the case right here. The size of the P wave here is about 1 millimeter in both height and width, which is considered to be normal. This is important because P waves that are large may actually indicate atrial enlargement. For example, if the height of the P wave is more than 2.5 millimeters in lead 1, 2, 3, or AVF, then this may indicate right atrial enlargement. And then I check if all the P waves are the same morphology, since arrhythmias like multifocal atrial tachycardias can have P waves of multiple morphologies. And in this ECG, all of them look similar. We can also see that each QRS complex is preceded by a P wave, and that there are no dropped P waves. Contrast this to cases of AV dissociation, like a third-degree AV block, in which the P waves will be independent of the QRS complexes. Then I look at the PR interval. As you can recall, this is the space between the beginning of the P waves and the beginning of the QRS complex. We have to see if it's prolonged or not, and whether it's constant or not. Normally, it should be less than 5 millimeters, which is the case here. If the PR interval is prolonged, this can be seen in the setting of a first-degree AV block. The PR interval should also be constant, like we have in this case, since a prolonged or changing PR interval can be associated with AV blocks. And then I make sure there are no PR depressions, which are mostly associated with pericarditis, a differential that should be in mind when assessing the patient with chest pain. So the findings of a normal P wave that is preceding each QRS complex with constant and normal PR interval make this a sinus rhythm. And then next we can look at the QRS complex itself. The first thing that I like to do is assess the width of it. It's normally less than 3 millimeters or 120 milliseconds, but you can clearly see that they are bigger than that. The most important differential for wide QRS complexes in the setting of sinus rhythm is a bundle branch block. But other causes of wide QRS complexes include ventricular arrhythmias, complete heart blocks, and the side effects of certain drugs. In this case, it's most likely a left bundle branch block, because if you look at the lateral leads, so leads 1, 2, AVL, V5, and V6, you can see that the QRS complexes are composed mainly of a wide, notched, and slurred R wave. That is the M shape that is usually described in left bundle branch blocks, and it's very clearly seen here in lead V5. In leads V1 and V2, there is a big S wave, which is also consistent with a left bundle branch block. Now, usually there is a notch here, which makes it look like a W. It's not seen here, but you don't need it to diagnose left bundle branch blocks. The other thing you can find in a left bundle branch block is loss of septal Q waves in the lateral leads. So as you can clearly see, there are no Q waves in these leads. Although you may find a small Q wave within lead AVL, but that's just the one exception, and we also don't have that either in this case. The other thing that you can find are the ST segment changes and the T wave changes. Now these are considered to be part of the left bundle branch block, and these are considered appropriate discordant changes. So when the QRS complex is positive, as in lead V6, it's accompanied by ST segment depressions and D wave inversions, so that they are in the opposite direction. And when the QRS complex is negative, most clearly seen in lead V2, there is an associated ST elevation and upright T waves. So the ST segment changes and T waves are in the opposite direction of the QRS complexes. And that's good because concordant changes, so when they face in the same direction as the QRS complexes, These are considered abnormal, and they may represent ischemic changes, especially if a patient presents with chest pain. And also, they're considered abnormal if the ST elevations are too excessive. And the way you can gauge that is that if it's more than 25% of the preceding S wave, that is at least according to the Smith criteria, or more than 5 millimeters according to the Scarboza's criteria. In this ECG, there are no concordant changes and the ST elevations aren't too excessive. So none of the criteria of ischemia apply here, like the Scarboza criteria, the Smith criteria, or the Barcelona criteria. So obviously, when we're interpreting this ECG, it should be within the clinical context. But when you're assessing left bundle branch blocks, watch out for any ischemic changes which might be there. And if you want to learn how to diagnose a STEMI in the setting of left bundle branch block, I have made a separate video talking about that and the criteria used for it. So to summarize, our interpretation of this ECG is sinus rhythm with a heart rate that is regular of about 75 beats per minute with left bundle branch block. There are no concerning ischemic changes in this ECG, but obviously if there is a strong suspicion for acute coronary syndrome, a specialist can make the call of what to do next. Thanks everybody for watching this video. If you want more of this series, let me know in the comments. Give this video a like and see you later.